Hey folks, Professor Finn here. Today we're going to be looking at Chapter 15 of Embalming History, Theory, and Practice, the 6th edition by Sharon Gee-Mascarello. So let's go ahead and get the screen up, get the pen ready, and talk about treatments after arterial injection. So post-embalming treatments are routinely carried out after completion of arterial and cavity embalming. Numerous variables, including preferences of the embalmer, influence the order in which treatment is performed. So here is the recommended order. This is a perfectly acceptable order, but recognize there may be personal preferences where people do things out of this sequence. For testing purposes, this is the order 1, 2, 3, 4, etc. In professional practice, it is perfectly acceptable to do things kind of out of sequence. And realistically, everything in this bracket towards the top are things that could be sequenced however the embalmer likes. Me personally, when I am done an embalming, one of the first things I will check for is features. So my number one would be looking at my face, looking at my hands, and seeing if there's anything I need to do there, especially the face. Then after that, I would do my corrective treatments. Then I would pack my orifices, and then I would probably close my incisions. Those are things that are perfectly variable that suit my embalming style. For testing purposes, you're going to want to look at lists throughout the book as this is the order in which to do it. It is perfectly fine to do it in this order. So after that, it kind of goes into a non-variable order: final bathing and inspection of all body areas, application of adhesives to incisions, applying plastic garments, terminal disinfection of the instrument and prep room surfaces, removal and disposal of your personal protective equipment or PPEs, hand washing and related personal hygiene, and finally preparation of documents. So insufficient preservation can exist following arterial embalming when solution does not adequately distribute within the vascular system. Additional arteries are raised and injected closest to the affected areas. It is very important to understand that if you do not get adequate distribution or diffusion in one area of the body when you have finished your multi-point, or if you finished your single point or your split point injection, your next step is to inject that area separately. You go from that one point to a multi-point, split point to a multi-point, because this secures the best preservation. You should not go immediately to supplemental methods of embalming, period. Unembalmed areas that remain after these attempts will be treated by supplemental embalming methods. There are two supplemental methods of embalming: surface embalming and hypodermic embalming. Surface embalming is the application of an embalming chemical directly to the surface of the tissues. Surface embalming chemicals and compresses/packs are applied to both external and internal surfaces. Now, there's an important thing here. The word compress and pack are used interchangeably in our industry. When we refer to a compress or a pack, we are talking about something that is applied to the external, the external surface of the body. There is another term that we use that connotates the application of the same exact item to an internal surface, and it's really easy to remember because it shares the same prefix. The same first two letters, and that word is inlay. Okay? The word is inlay. I'm going to get rid of this right here. Rewrite that. Okay, inlay. So if I were to take cavity fluid, put it on a piece of cotton, and place it onto the top of my arm, I am looking at a compress or a pack. If I have autopsy torso and the flaps are open and I apply it to the wall that would be inside when the flap is closed, the better term for that is an inlay. Internal inlay. Surface embalming chemicals preserve, cauterize, dry, deodorize, and bleach tissues on contact, and many of these formulations contain phenol. You'll remember from Chapter 14, we talked about cavity embalming, that if you should spill cavity fluid onto the body, you want to rinse it off with cold water as quickly as possible because it may discolor the body. And that is because of the bleaching action usually associated with phenol. For treatment of severe conditions, something just happened there. Let's zoom back out. This is what I get for trying to modify the pen color on the fly. For treatment of severe conditions, products may need longer application times. Where a phenol compress is removed, the area can be rinsed with alcohol to stop further bleaching and drying action. The longer phenol has to work, the more it will dehydrate and create a dehydration discoloration. So if you need to stop it in its tracks, just simply wipe it down with plain alcohol. Creams and gels are applied directly to the skin using a wide bristled brush or poured onto cotton applied as a surface pack. Again, pack and compress, same exact thing. And if it's an internal surface, it's called an inlay. Gels are available in two choices, low viscosity or high viscosity, semi-liquid or gelatinous. Creams and gels are designed to rapidly penetrate tissues. They can remain in place on non-viewable areas covered with plastic sheeting or a plastic garment. Arterial fluid is not generally recommended as a surface embalming chemical. I know a lot of people that like to take trauma care, Intrafine, OTC, and they say, it doesn't have active dyes in it, pour it on a compress and put it in place. If you have nothing else, then you have to rely on what you have. But cavity fluid is better for this because it is intended to do what you are wanting it to do, penetrate a surface and get there. Arterial fluid is moderated to diffuse before preservation starts, so it does not penetrate the same exact way as cavity fluid. The penetrating action of arterial fluid is slower compared to cavity fluid and accessory surface chemicals. An arterial fluid designed to penetrate rapidly would not preserve, cauterize, dry, deodorize, and bleach tissues on contact. It will penetrate fluid rapidly because it is intended to take advantage of passive transport systems to get through your interstitial spaces, get into the cell, and then start releasing its preservative. It's a completely separate theory. Hypodermic embalming is the subcuticular injection of preservative chemicals using a hypodermic needle and syringe or a small gauge trocar. This method is used to treat both small, localized body areas and larger areas, such as the trunk walls of the autopsied body, a limb that did not receive sufficient arterial fluid, or an area that cannot be arterially injected. Hypodermic needles are available in varying gauges and lengths. Smaller bore needles, 18 to 22 gauge, are ideal for tissues of the face and hands. Larger bore needles are used for greater surface areas. Larger needle entry sites may be closed with a trocar button. Smaller sites can be sealed with glue. With gauges, the larger the number, the smaller the bore. The larger the number, the smaller the bore. So a 20 gauge is much smaller than a 6 gauge. An infant trocar or hypovalve trocar can be connected to the centrifugal embalming machine for the injection of large body areas. The arterial solution used for arterial injection can be used for hypodermic injection. It is recommended that it be strengthened with a high index arterial fluid, and arterial solution should only be used on areas that will not be viewed, as the dye in the fluid can blotch the skin. One of the things about using the solution you've been injecting with is those dyes are now going to be concentrated in one area, and they're going to become very unsightly. Cavity fluid, as well as specially designed accessory embalming chemicals, may be used for hypodermic embalming. Phenol solution should be reserved for localized treatments of discolored areas or tissues when bleaching of tissues is necessary. The phenol solutions would not be used for routine supplemental hypodermic embalming. So, two important things here. If you are looking to preserve, you want to use cavity fluid. If you are looking to bleach only, you want to use phenol. If you are looking to preserve, and as a side effect of the preservation, get some bleaching, etc., cavity fluid is what you're going to want to use. Cavity fluid should be the routine chemical that you use for hypodermic embalming. If you are only looking to bleach an area so it has a bruise and it is adequately preserved, the best thing you should be using there is phenol. Well-preserved tissues will not dehydrate at the rate of poorly embalmed tissues. Application of glue to the eyelids and lips reduces the effects of dehydration. The marginal tissue membranes of both lids and lips are moist and will rapidly dry, shrink, and discolor. This is also why we tend to put something like massage cream or stone oil on them, petroleum jelly, to prevent dehydration. Visible areas treated by surface inlays or compresses can be coated with massage cream or spray after the chemical is removed. The creams and sprays may also provide a good base for cosmetic application. Cotton can be placed over the teeth or dentures and moistened with cavity fluid. Use a hypodermic needle and syringe to apply a few drops of fluid. The lips can then be glued. The preservative works from inside the oral cavity to preserve the tissues of the lips and mouth. Cosmetic treatment can be immediate using this method of preservation. And again, sometimes you don't have the time. So get the cotton in there, put a couple drops of cavity fluid, your adhesive, close the lid, and immediately start applying cosmetic. Insert a small amount of cotton independently or in combination with an eye cap. Fill a small syringe and place a few drops on the cotton. Close and use adhesive to close the eye. In this case, it doesn't look like I see an eye cap. I mean, maybe these dots right here are the top of an eye cap, but it looks like they're basically filling out with a little bit of cotton. In facial areas where hypodermic needles would be used, most of the injections can be made from inside the mouth, or, don't know why this is taking so much time, hidden points of entry. So a great way to reinforce your restorative art classes is to use the same terms as they are used there. So when we are injecting from inside the mouth, we are using it as a hidden point of entry. In this manner, leakage will not exit onto the face. Unlike tissue builder, these chemicals have a tendency to seep from the point of puncture. Anything other than tissue builder will leak from the hole. In the autopsied body, large portions of the face can be reached through scalp incisions. The hands can be injected from either the palmar or dorsal surface. The needle is directed between the fingers, and the thumb and fingers are injected directly by guiding the needle toward the tip of the digit. Superglue adhesive can be applied to the needle puncture after injection to prevent leakage from the site. So in this first one, we can see that they're trying to get cavity fluid into the tip of this finger, and over here they've gone between the digits and they are applying they're probably applying phenol to the interior surface here. So what they've done is they've gone in with a fairly large needle, channeled, and then applying phenol. Cotton saturated with preservative can be inserted into the nostrils. Later, push the cotton further into the nasal cavity so that it will not be noticeable. A small gauge hypodermic needle can be used to inject a preservative solution from inside the nostrils into various areas of the nose. If hypodermic treatment is used, expect some leakage from the injection sites. Cotton can be placed within the nostrils to absorb residual leakage and later removed. The bridge of the nose, nasal septum, column nasi, tip and wings often need contouring for natural appearance. Careful handling and direction of the needle will prevent injury to the embalmer during hypodermic injection. Now, what it says here is contouring for natural appearance. Sometimes you place a little bit of cotton within the nose, just enough to push out the nair, the wing, so that the nose looks natural. We can either choose to push that higher and use it to prevent any sort of leakage or purge. The other thing we can do is just take it out completely at that point, after we've secured a good cosmetic feature and preservation allows the nair to stay where it's supposed to. For areas that will not be seen, such as legs or feet, supplemental treatments can be used to enhance preservation. surface embalming powders, and the use of diapers to contain the powder, or the powder can be placed in plastic garments, such as stockings, coveralls, or pants after the garments are in position. Powders can also be used to treat the interior walls of the abdomen and thorax in the autopsied body. Powders are not as effective as gels or liquids. Read the label to be certain the powder is a preservative and not just a deodorant or absorbent. Certain conditions such as arteriosclerosis, gangrene, and edema require additional injection of the legs. A combination of supplemental embalming methods can be used. If arterial treatment has been unsuccessful, the legs can be injected hypodermically. The solution injected can be undiluted arterial or cavity fluid because typically legs are non-visible. The legs can be painted with autopsy gels, and embalming powder can be placed into the plastic stockings. In the trunk area, hypodermic injection can be used when the tissues have received insufficient arterial fluid. Here we have an excellent example of someone using a trocar to go ahead and preserve the lower limb. So you see this is not a hypovalve. It doesn't look like a hypovalve. It looks like a needle attached to a stopcock. And then they can turn the stopcock, let the fluid go through, close the stopcock, and reposition, remove the trocar as necessary. Coveralls, pants, or a capri garment can be used, and embalming powder or autopsy gel painted over the areas being treated. When edema is a problem in the elbow area, hypodermic treatment can be used, inject it from the upper arm, paint with autopsy gel, and wrap with gauze. A plastic sleeve can then be placed over the treated area. In non-viewable areas where the infant trocar or hypovalve trocar has been used, the punctures can be sealed with a trocar button. This is why it is so important for you to get information regarding the type of clothes that are being used. So when closing your incisions, the two methods commonly used are sutures and superglue adhesive. So best practices prior to incision closure. Do not suture until after cavity aspiration. Aspiration relieves pressure on the vascular system and helps to prevent leakage. Be certain all vessels are securely tied. This prevents any further leakage. If there is edema in the surrounding tissues, force as much liquid out of the incision as possible. Dry your incision. This may also include use of a hair dryer. There we go. A hair dryer or a phenol compress. Just put some cotton in there, add some carbolic acid to the cotton, and that will sufficiently dry the interior and seal any small holes. Which is the next item. Cotton saturated with a cautery solution can be placed into the incision. The compress can remain within the incision if you want. I tend to take them out and replace it with fresh cotton. That's just me personally. The addition of incision seal powder will also help to prevent leakage. Almost everyone uses incision seal powder. Make several sutures before adding the incision seal powder to the incision. Pull upward on the suture thread to create a pocket and direct the powder into the pocket. So let's talk about this for a second. When you are adding your incision seal powder, you really should do what this book is recommending. Make your first couple of stitches, pull up a little bit to make the pocket, and then place the tip of the applicator inside the pocket and put in your incision seal powder. What you should not do is let the tip of the applicator come into contact with any moisture or the surrounding tissues, because what will happen is the incision seal powder will activate and it will start to clog the tip of the applicator. After suturing, apply a liquid or spray sealant to the area to prevent further leakage. When it comes to suture thread, linen thread is stronger than cotton thread and is recommended for autopsy, long bone donors, and vessel incision sutures. For restorative sutures, which are located on visible areas, dental floss is an excellent material to use. So what type of needle should you be using? Well, everyone has a preference for this. For testing purposes, The right answer is what the book says. Okay? A 3/8 inch circle needle is used for restorative sutures and to suture incisions made to raise vessels. So the best needle to use is a 3/8 inch circle or semilunar needle. Double curve S-curve postmortem needles can be used for autopsies because they're easy to grip with a gloved hand. It's used to close autopsy incisions, long bone donor incisions, surgical incisions, and incisions made to raise vessels. Now, the thing about the S-curves is they come in a variety of sizes. That's an important thing to note. They come in a variety of sizes. The larger the needle, the larger the hole. And what you don't want is the hole to be larger than your suture thread. So if you are using an extremely large needle, you may have to double up your suture thread in order to plug that hole adequately. Some suture needles have a patented spring eye for the easy threading of the needle. Regardless of the size or the shape of the needle, it is most important to keep them sharp. Suturing can be very dangerous if the needles are dull. To tighten the suture, pull on the thread and not on the needle. Pulling on the needle weakens the suture thread where it passes through the eye of the needle and breakage can occur. Now, embalmers can use either single or double-stranded thread. This depends on the strength of the suture thread or the type of suture. So, a lot of students I've had, especially in most recent years, before I stopped teaching actively, say that, my preceptors say always double up your thread. And they're using like 7-strand or 6-strand suture. There is no need to do that with 6-strand suture. That is a very large ligature that you're trying to pass through, and that's really going to spread and open things maybe the way you don't want. So, if you are using very small suture thread, such as 3 or 4 strand, you probably want to double that up so it's forming something along the lines of a 6 or an 8. If you're using single strand, just go with a thicker suture thread, such as 5, 6, 7, or 8 suture thread. Dental floss also works in a pinch. I've had some people when disasters occur run out of suture thread and start using fishing line. Not going to say you can't. Just going to say that ultimately you're using something that is either intended for use or something that is not going to provide a wicking action where moisture will be put up. Fishing line is an alternative. But remember, whatever you use has to be able to plug the hole that is made by the needle. That is the point of this. So, direction of suturing. Common carotid artery. If using the parallel incision, suture from the inferior portion to the superior portion. Suture from the medial portion of the incision lateral if using a supraclavicular incision. So remember, when we are talking about suturing on a carotid, the embalmer is standing at the head of the table, okay? And you're suturing with the body in front of you, and you will suture from bottom to top. Axillary artery, from the medial to the lateral. Brachial, medial to lateral, and radial and ulnar from the distal to medial. This is the exception to the rule. Okay, the radial and ulnar arteries are the exception to the rule. So all the horizontal incisions we've seen are medial to lateral, inside to outside. With the wrists, it's outside to inside. And you might say, Professor Finn, why does this matter? Where you start your incision, okay, where you start suturing your incision, forms the tightest pocket that will prevent leakage. So if we start at the bottom and work our way to the top, fluid is going to probably gravitate towards the bottom of the incision because, remember, our head is up on a pillow. If that is the most leak-proof or leak-resistant, that is beneficial for us. So when you are suturing, this is where you really want to place that initial suture and start your work, because of the fact that is going to be the area that is least likely to form a leak in the future. Femoral artery, inferior to superior. Popliteal, inferior to superior. And tibial, distal to superior. Again, bottoms to top. Autopsies. Use bridge sutures to align the skin into position. Begin the trunk suturing at the pubic symphysis and suture superiorly. So again, bottom to top. For the most part, everything is bottom to top. Bridge sutures temporarily align tissue margins and secure them in position until permanent sutures replace them. Numerous bridge sutures are placed to align the tissue flaps of the Y incision created during autopsy. Here is an example of a bridge suture. You're simply going in one place, coming out the other, and then tying your ends. And you can see they are using a circle needle to do that. A baseball suture is the most commonly used suture to close incisions. It is considered the most secure and leak-proof. In addition to the closure of the incision at the injection site, it is suited for closure of lengthy incisions as an autopsy surgery and long bone donation. As you can see here, this involves an alternating pattern. You are going from the inside out, over, inside out, over, etc., etc., etc. To make this stitch, pass a suture needle and thread from beneath the incision up through the integument and cross the needle from side to side with each stitch. The resulting lacing pattern is similar to the stitching on a baseball. You see the example of a baseball stitch here. And you can see that what happens is you go into the incision and then you poke through from the inside, going to the outside, and then alternate to the other side and repeat. As each stitch is pulled tightly, the tissues adjacent to the incision pucker and create a visible ridge on the surface. When the baseball suture is used for the closure of lengthy incisions, the thread can be knotted or locked down every few inches. Then it is known as a locking stitch. Okay? The only difference between a baseball suture and a locking suture is how you treat the stitch, not so much the technique for the stitch. So right here, what you can see is the thread comes through and the needle goes over the top, right? And when you pull that, it goes and creates tension all the way back to the beginning. In a locking stitch, what would happen is you see where the needle is over the thread here, you would actually want the needle to go under the thread. And when you pull it tight, what will happen is it will create a knot right there. That is a locking stitch. To lock the suture, pass the needle through both sides of the incision and tie a knot as though the suture were completed. Do not cut the ligature. Use the same thread to continue suturing. Locking down the suture will also relieve the tension from the thread, minimizing fatigue to the embalmer's hand during suture. So before we get to more sutures, I feel the most important thing that you need to deal with when working with sutures is you must have constant tension on your suture. The constant tension will keep it nice and locked down, so as you go, you won't have to pull too hard and try to tighten things. Everything will be tight as you go, and you'll get the best type of result. The interlocking suture continues throughout the closure until the occasional lockdown practice above. A tight, leak-proof closure is created. It is, in all essence, a baseball stitch, except the ridge is a little bit different where you lock it down. The disadvantage of the interlock or the baseball stitch is that really ugly ridge that it forms. To begin, direct the needle through both epithelial margins of the incision. Keep the thread tight with the hand not holding the needle. Lock the stitch by looping the thread and passing the needle through the loop. Pull the thread tight. Insert the needle in the same side of the incision. Each time the process is repeated until the incision is closed. So if you are doing a true lock suture, you are tying it down at every stitch. That is a bit overkill, but you may need to do that in some cases. So the intradermal, not to be confused with a worm suture. The single intradermal suture is made entirely within the dermal layer, traversing the needle side to side within the incision. The needle does not pass through the epidermal tissues, and the thread is hidden from view. So if we were to look at this from the outside, here on the margins, okay, what we would see is this. The only thread we would see is the stuff that is coming through the actual margins of the tissue. If you have very thin tissue, that is kind of a problem because you have to have something to anchor on the inside. The anchoring occurs right here on the inside of the tissue, not on the outside. When you pull it together, everything comes together nice, and then you have to put incision seal on the top, such as True Sealer or super glue or something like that. To begin the closure, insert the needle deep into the dermal tissues at one end of the incision, make a knot in the thread a short distance from the end, and pull the knot to the position of the needle entry in the integument. Direct the needle in a back and forth pattern from one side of the incision to the other. Align the margins of the incision as the thread is drawn to prevent gaps and tissue misalignment. To complete the closure, direct the needle through the integument as far as possible from the end of the incision. Draw the margins of the incision together by pulling on the free end of the thread. Puckering will result if the thread is pulled too tightly. Pull upward on the thread and cut the thread at the tissue of the surface. Your excess thread should disappear back into the incision. A double intradermal suture simply means you're using two needles. The double suture is knotted at each end, creating greater holding strength than the single intradermal suture. This is also a dermal layer suture. The same thread is used for the two needles. One needle is threaded at each end. A full description is available in your textbook. It's, again, this, except with two needles, using both ends of the thread. I'll be honest, I have never done a double intradermal. I have not found them relevant for my needs. The worm suture, or the inversion suture. The inversion suture gathers and turns under excess tissues. Inverted tissues create a flat closure, a visible ridge on the skin surface is avoided, and the incision is easily concealed using either wax or Easy Way, which is a form of liquid latex, something of that nature. After completion, the knot can be pulled into the incision and the excess thread cut closely to the surface and no thread is visible. The lacing pattern is similar to the single intradermal. So, what is the difference between the two? Well, this is not done from the inside of the incision. It's done on the outside, kind of like a baseball stitch. So what you are doing is you're coming in and out on one side, you then come across, you come in and out on the other side, you come across, in and out on the other side, come across, and you form this pattern on the top of the skin. So from the top, if we were looking at this down and this incision was closed, this is the thread that we would see. Every one of these points is where the thread would come out. Now, these are hidden in the final product because we pull it together and it folds under itself, as you see here. Stitches are made on the surface only. The needle passes back and forth over top the skin surface rather than into the dermal tissues. Each stitch is made parallel and close to the margin of the incision. Stitches that are uniform in length and drawn moderately tight produce an optimal closure. The moral of the story is you want the ins and outs to be as aligned as possible, and the ligature to be as parallel as possible. And it forms something like this. The inversion is ideal for suturing the cranial autopsy incision and the smaller incisions used for arterial injection. The inversion suture is not drawn as tightly as the baseball and may not be suitable for trunk autopsy incisions. This means it is also more prone to leaking. And when they say, well, Professor Finn, this looks pretty bad, still looks like you have something there, that is true. Okay, that is true. The moral of the story is you can very easily fill this with wax, and it'll disappear. It'll literally disappear. The whip suture is used to temporarily close lengthy incisions. Disadvantages include a visible tissue ridge, visible suture thread, and leakage potential. The exposed thread can draw or wick body fluids. The thread will remain wet. Surface glue may not adhere, and clothing can be soiled. Realistically, we do not use a whip suture for very much in mortuary science. Routinely, the whip suture is used by autopsy and organ procurement technicians to temporarily restore the body cavities for transfer to the funeral home. That's it. Now, I find that funny because my experience has shown me when I was receiving autopsy cases from our local medical examiner, they don't even do whip stitches. They just do a couple of locking bridge sutures, and that's that. I would have to pop 3 bridge sutures, and I would have the flaps completely open. Maybe 4. To make this stitch, direct the needle through both epithelial margins of the incision. Reverse direction of the needle and pass over top the skin surface back to the initial needle entry site. Place the next stitch 1/2 to 1 full inch beyond the previous stitch. Repeat until it's closed. So you go in here from the top. You go through the inside. You come out on the other. You bring it over to the next side. Go in, come across, come out, and you repeat over and over until it's done. So concealing your suture. The final length of thread and the knot can be completely hidden when suturing is complete. This practice prevents any exposed thread from wicking moisture from the incision and remaining wet. The incision can be easily concealed when the clothing provided does not hide the incision. Application of cosmetics and restorative waxes can be used for concealing. So you can see that the suture was finished. They came back in through the bottom, pulled it through, came out here with the needle, pulled it tight, and then cut at the surface of the skin, and the thread should pop right back in. I don't know what has gotten into people over the last couple of years, but the number of cases that I have seen, especially even on social media, so these are cases that are being publicized by their funeral home saying what a great job they've done, is I'll see a piece of ligature hanging over the ear from a person who's had a cranial autopsy. I've had people send me photos of that. Say, yo, I'm at a service right now, and this is the way my loved one looks, and I see ligature thread literally hanging out in certain places. And realistically, that's just sloppy as hell. There's no excuse for that. Clean up your work. Hide your work. At the completion of suturing, place a knot in the thread. Move the knot as close as possible to the surface of the skin. Do not cut the thread. Place the needle beside and directly against the knot. Drive the needle into the incision 2 or 3 inches away from the knot and exit the incision. Pull the thread taut. With a quick snap on the thread, the knot will disappear. Excessive force will pull the knot too deeply. The objective is to hide the knot just below the epithelium, yet keep it embedded in the dermal tissue so you don't really have any bad puckering and pulling of the skin. Cut the tail of the thread close to the surface, and it will disappear into the incision. Apply adhesive glue to the exit hole. So, super adhesive glue and bonding agents. Super adhesive glues and bonding agents can be used for some closures in place of sutures. A variety of types are available. Some are suitable for bonding in the presence of moisture. These adhesives are a good choice for sealing jagged tissues that cannot be sutured. Routinely, glues are applied to sutured incisions to prevent leakage. The tip of the applicator can be used to apply the glue directly, or the glue can be applied first to an instrument for application. Clean the instrument or applicator tip after use to prevent buildup. It is not uncommon to see toothpicks in a prep room. And when they're done, they just take the wooden toothpick and throw it into the sharps container. Removal of invasive medical devices. So pacemakers and defibrillators. Both these devices contain batteries that must be removed when cremation is the method of final disposition. Batteries create explosions and injury hazards during the cremation process. Remove the device through a small semilunar incision. Best practice is to cut wire leads independently with surgical scissors. Close the incision by suturing or application of a bonding agent or super adhesive glue. Typically, I would just suture these. A colostomy is the opening of the colon through the abdominal wall to the skin surface. The stoma is the exposed portion of the bowel. To remove and disinfect the colostomy collecting bag before disposal in a biohazard waste container. Topically treat the area with a compress of cavity fluid or a phenol solution. The stoma can be reinserted into the body cavity using firm pressure, and either of the purse string suture or the reverse suture can effectively close the colostomy. Seal the closure with glue to prevent leakage. Now, that being said, if the colostomy is attached to the body, it is solid, it is not moving, I have seen embalmers just kind of tape it down and be done with it. I'm not saying that that is the ideal way of taking care of it. I am saying in practice, removing a colostomy bag just to remove a colostomy bag, I will leave that up to your personal conscience. For testing purposes, you remove the colostomy, you disinfect it, you suture it up, and glue it shut. Surgical drains are placed post-surgically to prevent the accumulation of blood, pus, and infected fluids, to prevent accumulation of air, and to identify the type of fluid leakage. Remove surgical drains and close openings using a purse string suture. So, treating discolorations and ulcerations. Additional treatments for discolorations and ulcerations continue after embalming. Discolorations may be bleached at this time in preparation for cosmetic and restorative applications. Ulcerations may be treated a second time to ensure sanitation before dressing. With purge, after arterial and cavity embalming, the possibility of purge exists from any of the orifices. Tightly packing the throat prior to mouth closure and arterial injection can decrease any purge from the mouth. Treatment of purge has been extensively covered in the previous chapter. I'm not going to discuss it at length. So, swelling, distension. Visible areas such as the face, neck, and hands that are distended may need to be reduced for viewing of the body. These treatments can be carried out during the post-embalming period. It is necessary to know the cause of the distension to perform the best corrective treatment. Swellings present before arterial injection should be documented in the embalming and decedent care report. It is essential during embalming of the body that the embalmer is alert to any tissue distension. Injection should be stopped immediately and the situation evaluated and remedied when distension starts. Edema of the eyelids can be treated in several ways, using weighted surface compresses, cavity fluid on cotton under the eyelids, during and after injection, hypodermic injection of phenol compound or cavity fluid after embalming, or use of a tissue-reducing spatula after embalming. A side effect of removing edema from the facial tissues or hands is that the skin may become very wrinkled. It reminds you here, tissue preservation is always your primary concern. Everything else we can treat with wax and cosmetics, but if it's not preserved, we can't do any of that. The tissue-reducing spatula may also be used to remove wrinkling from the eyelids. You might say, what is a tissue-reducing spatula? It is literally a soldering gun that has a different tip. Gases can easily be detected after death by palpating the tissues. The term crepitation is used to describe the spongy feel of the gas as it moves through tissues when they are pushed upward. Let's go back to red. Gas that is trapped in the facial tissues must be removed by channeling. Channeling can be done post-embalming. A scalpel or hypodermic needle is used to channel the affected facial tissues from inside the mouth. Once the channels are made, the gas can be manually squeezed from the tissues. Why inside the mouth? Hidden points of entry. The features can be corrected after resetting and gluing the features. The features can be corrected after embalming. Additional cotton or mastic compound can be inserted to fill out sunken and emaciated cheeks. The mouth can be reopened and the dentures inserted afterwards if necessary. These procedures are more difficult when the tissues are firm and less pliable. Eyes can be closed or reset after arterial injection. And the skin of the lips and margins of the eyelids should be clean, dry, and free of moisture or oils, including massage cream. Hint, hint. Super adhesive glue works very well for securing the eyelids. Apply glue to the mucous membranes behind the weather line. If the body was transferred from another funeral establishment, the lips may separate during travel or during a flight. During the delay, the tissues have additional time to become very firm. In such cases, the lips can be stretched or exercised with the blunt handle of an aneurysm needle or a pair of forceps. If the eyelids separate, they may also have to be exercised or stretched to obtain closure. Superadhesive glue is more effective in securing the mouth and eyes when the tissues are very firm. Fancy way of saying this stuff is always going to want to go back to its normal form if they've opened up. Only way to prevent that is to glue it. So final inspection and bathing. After final inspection of the entire body, shampoo the hair and bathe all areas to remove dried blood and chemical odors. Thorough drying eliminates the potential for mold growth on skin surfaces, especially in warm climates. Apply a massage cream or spray to face and hands and cover the body completely with a full sheet. A layer of plastic sheeting to cover the face will decrease surface evaporation. Again, most of the time, a little bit of massage cream or petroleum jelly or whatever your firm uses to prevent dehydration on the face can be used in lieu of or in addition to the plastic sheeting. Prior to dressing, protective plastic garments can be placed on the body to contain any minor leakage and odors. Adult incontinence garments may also be used if minor leakage is anticipated. Be certain the body is thoroughly dried before using a plastic garment. Pants or coveralls can be placed on the trunk when the leakage from the orifices, ulcerations, or traumatic injuries is present. The capri garment is ideal for coverage of the full lower extremities from the hips to the feet. Plastic stockings are used after surface treatments of the legs, and plastic sleeves may be applied over broken skin at the elbows or on the arms. Place embalming and absorbent powders into the garment to control leakage, mold growth, and odor. If general edema, tissue decomposition, or extensive burns are present, a unionol may be necessary to protect clothing and casket fabric from soiling. The unionol is a plastic garment which covers the entire body except for the neck and head. Plastic garments are available in a variety of sizes. Best practice is to use a garment slightly larger than necessary. Best practice is to use a garment slightly larger than necessary. Terminal disinfection practices are carried out after the embalming process to comprehensively clean up all of the preparation room surfaces. The floors, countertops, cabinets, drawer handles, etc. are included. Instruments are cleaned, placed in a cold sterilant, dried, and returned to countertops or drawers. Now, for some of you, this may be after every case because you have relatively low volume. For some of you, you terminally disinfect the embalming room at the end of the working shift. After use, the embalming machine is flushed with warm water. Fluids that contain a humectant such as lanolin or silicone often leave a thick residue in the tank. Ammonia and lukewarm water flushed through the machine removes the residue. A water softener or a dishwasher detergent is also effective. Fancy way of saying Dawn dishwashing detergent, the plain blue stuff, works wonders here. Embalming machine cleaners are available from embalming chemical suppliers, and if you are having a hard time getting that or you're just quote-unquote too cheap, good old-fashioned blue Windex, plain stuff, nothing fancy. Great way to clean your embalming machine glass because it is ammonia-based. Just with any ammonia cleaner, make sure you thoroughly rinse your embalming machine after you use ammonia or any ammonia-based product in cleaning it. After cleaning, fill the embalming machine 1/3 with fresh water to keep the silicone used to seal the tank wet. This prevents drying and shrinking of the seal and prevents leakage. A lot of us also add a water corrective at that time. Dissolved gases such as the chlorine found in tap water also have time to release before the next use of the machine. The later addition of embalming fluid to the water decreases the release of formaldehyde fumes. Place the lid on the tank of the machine in between use. All preparation room surfaces should be cleaned. First, be cleaned with cool water and a small amount of antiseptic soap to remove organic debris. A preliminary wash removes any debris and chemical residue present. Remember that many disinfectants, such as bleach, contain chlorine, and this chemical should not come into contact with formaldehyde. Bleach and warm water make a very good cleaning solution. The table, countertops, and drains can be wiped clean and disinfected with this solution. Be certain to clean the area under the table surrounding the drainage outlet. Tops of overhead lighting should also be given attention. Tubing used for aspiration should be soaked in a disinfectant solution. Pay attention to handles on cabinets and drawers. Commercial products used for cleaning the preparation room contain dilution instructions. Follow the instructions. Clean instruments prior to disinfection. Removing organic material from the instrument makes disinfection more effective. Immerse all instruments, including trocars, in a cold sterilant solution according to product usage guidelines. Dispose of used cutting blades in a biohazard sharps container. Take special care with non-disposable cutting instruments. When gas gangrene or tissue gas has been encountered, they should remain in the solution several hours. Always check your disinfectant instructions on the container to see what the protocol is for Clostridium perfringens, and make sure that you are following it to the letter. After disinfection, instruments should be rinsed, dried, and properly stored. Personal hygiene practices apply to the embalmer. Removal and disposal of PPE, hand washing, bathing and showering, laundering of washable garments, and other modes of hygiene or practice after embalming. Best practice is to wear surgical scrubs instead of work attire beneath PPE. Include the cleaning of the nostrils of the nose where odors can linger. Nose hairs act as a natural filter, preventing the entry of foreign particles such as dust and pollen, bacteria, spores, and viruses. Particles stick to the wet surfaces inside the nose to prevent inhalation. Harmful particles that are inhaled into the lungs may cause respiratory infections, or worse. Finally, complete the appropriate embalming and decedent care report for every deceased. The report should contain specific information related to the pre-embalming conditions of the deceased and personal effects received with the body. Inventory and document all personal items. Document all decedent care treatments performed. The report must accompany all bodies being prepared. The viscera was retained by the postmortem examiner or returned with the body is an important thing to note. Organs and tissues recovered for donation must also be noted. When viscera are treated during embalming and returned to the body cavities, note the method and the chemicals used. When in doubt, write it all down. Don't just say I used a 30 index cavity chemical. State the specific cavity chemical and state the specific quantity that you used. And when you are done, if you have a supplemental care form, use your supplemental care form to show any further treatments so that your embalming report is not further being altered. Bodies should never be shipped without some form of covering. Place undergarments, hospital gown, plastic coveralls, or pants on the body. When positioning instructions have not been given by the receiving funeral home, make certain hands are not placed one on top of the other. Place the hands separated upon the abdomen. Resting one on top of the other can create indentations. The receiving establishment may prefer to reverse the hands for custom or preference. A light coating of massage cream or spray can be applied to the surface and hands to prevent surface dehydration during shipping. Live floral arrangements that are placed inside of a casket or shipping container can cause excess moisture. Certain flowers also have staining properties. When the body has been autopsied before shipping, the report should indicate whether memorial items and personal effects placed into the container should be documented. Inform the receiving funeral home of the items and indicate where they will be found. I got to look at, so I'm going to just go back for a second to this slide. I'm going to look at this after the fact, and I'm not going to re-record anything, but it looks like there may be some language missing from a copy-paste job here. So I will fix that in my slides for maybe a future re-recording. But something seems wrong here because I don't know what an autopsy has to do with reporting whether memorial items and personal effects are placed in the container. Generally, you want to record on your shipping documents if you are placing stuff that's in there, and have very good communication with the receiving funeral home as to what's being placed. Periodic monitoring of the deceased and performance of the treatments necessary to maintain post-embalming stability is an ethical duty. Periodic surveillance is also called custodial care. The dignified care of all human remains is expected of all professional death care providers. Extended periods of storage prior to final disposition create additional opportunities for adjustments and corrections. I have been retained more than a handful of times at this point as an expert witness when it comes to embalming, negligent embalming type of cases. One of the most common things that I find when I am doing an analysis of a situation for a plaintiff or an insurance company is the lack of custodial care. You embalmed it, you put it in the refrigerated storage, and you forget about it until a day or two before the funeral. That is unethical. It is unacceptable. So the part of custodial care. Your custodial care may include cosmetic and feature setting adjustments, treatments for discolorations, leakages and purges, the presence of mold and infestations by insects. Re-embalming may be something you have to do. Clothing can be protected by sheets of plastic. The casket interior, pillow, and clothing should be inspected for any signs of leakage. If leakage is judged severe, the body should be removed from the casket and carefully undressed. Incisions can be opened, dried, and checked to be certain vessels are ligated and resutured using large amounts of incision seal powder within the incisions. Plastic garments can be placed on the body and, if necessary, edges sealed with mortuary tape. Interior damage may be severe enough to require replacement. Casket pillows can be reversed for minor leakage. Blankets and clothing may need to be replaced. Our friend the maggot. Infestation of the body with maggots is a nightmare experienced by few embalmers today. In the summer months, bodies should be carefully examined for fly eggs, in particular the corners of the eyes, within the mouth, and the nostrils. If maggots are present, they can be picked from the surface of the body with cotton saturated with a hydrocarbon solvent. To stimulate maggots to emerge from the surface from areas beneath the skin or from the mouth or nostrils, the areas can be swabbed with a petroleum product. They should be placed in plastic bags before being discarded. The challenge with maggots is not knowing if all have been found. Maggots found on the clothing and hair can be vacuumed. Properly clean the vacuum canister on the vacuum. Last up, we have mold. In warm climates, mold can be a problem when bodies are being held for long periods. Bodies should be thoroughly dried to discourage mold growth. Mold needs to be carefully removed with a scalpel or spatula. The area is then swabbed with a phenol compound chemical and later thoroughly dried before cosmetics are applied. Placing embalming powder inside plastic coverall pants and or stockings helps to control mold growth. Mold is a huge problem for us. It leads to discolorations. You have to scrape things off, which then leads to high cosmetic application. Controlling mold should be one of your greatest concerns when you're looking at long-term storage of bodies. Folks, that concludes this lecture, and we will see you next time.